Welcome to the lecture for Module 5 of Medical Ethics Online. I'm Eli Weber, your instructor, and today we're going to talk about some of the different relationships that are relevant to decision making in medical ethics. One thing that we started out talking about in Module 1 was the extent to which some of the obligations that seem relevant in medical ethics follow from the way that we understand certain roles. The way that we understand the role of a physician leads to certain obligations that we think a physician has, for example. And so one thing that we ought to look at, if that's true, is what these roles ought to look like, what these relationships that are a consequence of these roles ought to consist of. Because there are different ways that these relationships can be formulated. And if the role that a physician or a nurse occupies leads to obligations for that individual, we ought to think about what that role ought to look like and ought to consist of. So that's kind of the point of thinking a little bit about relationships and their relevance to medical ethics. The goal of this lecture, there are 4 goals that we can specify that we should just briefly discuss before getting into the details. First, we're going to talk about 3 distinct conceptions of the doctor-patient relationship. There have historically been 3 different conceptions that have been dominant, and I think in laying out these 3 conceptions, we're going to quickly see that one conception in particular is obviously the better one, although there's still room for some debate about the significance and importance of the other 2. Then we're going to consider, after talking about these conceptions of the doctor-patient relationship, we're going to talk a little bit about what obligations we think fall out of this relationship. In addition to that, and kind of as a component of it, we're going to think about whether patients have any obligations to physicians as a consequence of entering into this treatment relationship with the physician. Then we're going to briefly discuss 2 approaches to the problem of truth-telling in medicine, because there's quite a bit that we can say about the doctor-patient relationship and how it kind of ought to proceed. But one of the ways that we can get clearer about what that relationship should actually look like is to think about what role it plays in a specific problem in medical ethics. So for our purposes, we're going to take a look at truth-telling. And we're going to conclude by evaluating 2 different conceptions of the role of nurses. This isn't something that gets discussed quite as much in medical ethics, but because I know so many of you are nursing students, it seems like it's worth it to spend a little time just talking about the different way that we might understand the role of nurses and think a little bit about reasons in favor of those different conceptions. And remember, the goal here is not descriptive, right? We're not talking about what the role of a doctor is or what the role of a nurse is. We're talking about what that role should be. We're talking about what the doctor-patient relationship ideally ought to be like. We're not doing sociology, doing medical sociology here. We're talking about ideals. We're talking about what should be the case, not what is the case. All right. Let's talk briefly about these 2 kind of deficient conceptions of the doctor-patient relationship. One of them is the notion of the doctor as a technician. On this view, the doctor is very much like a mechanic in that they diagnose the problem, provide the relevant empirical information, explain what the options are as far as fixing the problem, and then they let the patient decide. When you go to the mechanic, that's what your mechanic does. He or she tells you what's wrong with your car, just empirically, here's what's going on, you've blown your transmission, here's what you would need to do to fix it, here's what it'll cost, etc., and you decide, all right? You just make a decision. Now, the conception of the doctor as technician, medicine is really not so different from things like auto repair. It's a value-free objective science in the sense that there's just empirical data and there's just a standard procedure for how to deal with the problem that's diagnosed. There are no value judgments associated with providing that information, according to this conception of medicine. Now, you might think, and hopefully you do think, that that conception of medicine is actually false, that in fact physicians and researchers are making evaluative choices and decisions all the time. Researchers make evaluative decisions about what problems to pursue, how to pursue them, how not to pursue them. Physicians make value decisions all the time as well in deciding what risks to discuss with their patients, what risks to not discuss. They're making assessments of what they think might be important to a patient in that case. That's a value judgment. That's not an empirical matter. So that's obviously going to be one problem with this conception of the physician, is that the doctor as technician relies on a conception of medicine that probably isn't true. But for our purposes right now, all we're trying to do is get clear about how this role is conceived, what the idea is when we're talking about the doctor as technician. And basically, the idea here is that the doctor, his or her job is to provide the relevant information and then let the patient make a decision. And it's really heavy emphasis on patient autonomy in this case. The patient just decides, and whatever they choose, that's what's done. Another way of thinking about this relationship is basically just the mirror image opposite of the doctor as technician. This is the notion of the doctor as omniscient and omnipotent. On this view, the physician is in a special privileged position of both knowledge and authority. So the physician is the only one who's really qualified to evaluate the relevant medical information, and what the patient really ought to do is just whatever their physician says they should do. So this is the somewhat dated doctor knows best understanding. Although I noticed on the discussion board of Module 1, and we can sort of, this is worth noting, someone posted a discussion of an experience with a nurse who basically became upset or agitated with a patient when they were refusing a treatment, and made a comment to the effect of, well, what could I possibly know? I'm just a nurse. Although that was a nurse, this suggests that the medical field knows what's best for you. You should just listen to what we say. That attitude is not gone. There is very much a continuing and pervasive sense in the medical community that they really know what patients ought to be doing, that the patients are, if patients were smarter, if they were at least more compliant, more willing to listen to what they had to say, their health they would be better off health-wise. Now notice that there's a huge problem with this conception of the physician, namely that the expertise of the physician is highly limited, right? What the physician really knows about is the medical facts. What the physician does not know about is your value hierarchy, what's important to you, the patient, what matters to you, what kinds of things you are and are not willing to tolerate and put up with, and that sort of thing. So the physician is not necessarily privy to important facts about you that are going to be relevant to making a decision about medical treatment. So that's one concern about this conception of the role of the doctor and the doctor-patient relationship, is that it gives the physician a bit more credit and endows the physician with greater knowledge than they in fact have. The other concern is that it's not clear where patient autonomy actually is on this conception of the doctor-patient relationship, because it seems to put the patient in a position of deference to the physician. Luckily, there is another option. There's a kind of middle way. There's a hybrid view that combines positive features of the other views without sort of overdoing it, without moving to the extremes that the other two positions wind up advocating. On this hybrid view, the physician's role is more complex than just providing information. So the physician has to do more than be the technician. They also have to take stock of other considerations that bear on patient autonomy, things like psychological well-being. Part of respect for patient autonomy is not just giving the patient all the information, but making sure that the patient really understands the information. So this might involve things like repetition or presentation of the information by, a second source, so that it's reinforced that this really is what's going on. the physician might have to do things like take stock of psychological considerations. Is the patient depressed? Is the patient in a position where they might be overvaluing certain considerations? Maybe failing to understand what sort of low percentages suggest for the likelihood of positive outcomes, for example. So the physician's role is just more nuanced on this hybrid view. It's more than just the technician. And then the patient's right to autonomy is less absolute than on the technician view. The patient, it's recognized on this middle or hybrid position that the patient's autonomy can be compromised in a variety of ways. And so part of what that physician's job is part of that role is to restore the autonomy of the patient by attending to things like vulnerability associated with illness or psychological impairments and that sort of thing. So what we have here is it's a more realistic understanding and viewpoint about patient autonomy, both what it consists of, how it can be compromised, and what the physician can do to sort of restore that autonomy. We'll talk about this a bit more when we get into discussion of truth-telling, because what this hybrid view is really doing is taking some of the considerations discussed by Terence Ackerman pretty seriously. The idea that illness can undermine patient autonomy in important ways, and so the physician has to do more than just not interfere with choice. The physician actually has to facilitate autonomous choice in a lot of cases. Okay, so what does that have to do with physician obligations? Because what we started out with in our discussion was the idea that in virtue of the way we understand the role of the physician, the way we think about the physician-patient relationship leads to obligations on the part of the physician. Well, one of those obligations is going to be a high degree of confidentiality and privacy. This has to do with the fact that the physician is charged with protecting and preserving the well-being of the patient. We think that the patient's well-being is compromised in a variety of ways if their privacy is not respected. Another of the physician's obligations that follows from this conception of the doctor-patient relationship is veracity, which just means truth-telling. The physician, it seems, is obligated to tell the patient the truth. That's part of respect for autonomy, and also it's part of establishing informed consent. Respect for autonomy, obviously, is going to be another obligation of the physician that follows from the fact that the patient has certain rights. And finally, the physician, we tend to think, has an obligation of fairness to treat patients roughly the same way under similar circumstances, and shouldn't favor one patient over another in virtue of arbitrary features like race or gender or age or something like that. So those are just some of the obligations that we think falls out of the role of physician. And notice that some of these are going to be socially prescribed, and some of these are going to have to do with requirements of the relationship itself. For example, patients are going to be less likely to tell their physician everything that's going on with them health-wise if they don't have an expectation of confidentiality and privacy. They're going to be less likely to trust their physician if they don't feel like they're being told the truth. They're going to be less inclined to, seek treatment and follow through with treatment if they feel like they're not being treated fairly. This all has to do, a lot of these obligations follow from not only the content of the relationship, but also the ends of the relationship, the goal of medical treatment. In order to achieve this goal that medicine is supposed to be about, which is keeping people alive and making them healthy and making them feel better physically and mentally, we have to have certain structures in place, and the way to make that happen is to obligate the physician in certain ways. Although we might think a little bit about whether or not patients have obligations within this relationship as well. One potential patient obligation that comes up is an obligation to tell the physician the truth. we should bear in mind that the physician is a skilled professional whose time is quite valuable. The physician also represents a limited social resource, so it might be that in order to not waste the physician's time, both for the physician's sake and the sake of other people who might also need to see the physician, patients have an obligation to be open and upfront and honest about what's going on with them, the exact nature and extent of their condition. And as a consequence of that obligation, or as a reciprocal of that obligation, the physician is obligated to protect patient confidentiality. We sort of need both of those things in place for that relationship to work efficiently. Another potential obligation of the patient might be compliance. There's sort of disagreement about this. If you had a sort of strong conception of patient rights, you might think that the patient can sort of do what they want with regard to treatment recommendations. They can take their antibiotic or not, for example. Or you might think that actually patients, upon entering into a treatment relationship, are obligated to comply with what they have agreed to do. We tend to think that our own agreements obligate us in certain ways. If I promise to take you to the airport, I am obligated to then actually do so when the time comes. So you might think that by agreeing to follow through with a treatment recommendation, the patient obligates themselves to comply with that recommendation. And we can also think about things like, again, sort of the limited resource that the physician represents, and the fact that if you're going to sort of take up that resource, you are obligated in virtue of an obligation to others. You're obligated to then comply with the recommendations that resource, in this case the physician, gives you, because you're taking that resource away from other people. Although the compliance obligation is a little bit more controversial. Not everyone agrees with that one. The truth-telling obligation people tend to find slightly more plausible, and you can kind of decide what you think about that. But what we should sort of pause and consider briefly here is, if the physician has obligations, but the patient also has obligations, we ought to consider who really bears the bulk of the responsibility in this relationship. People tend to think, well, it's obviously going to be the physician because they're better trained, they're more skilled, they're in a position of power, and so with great power comes great responsibility, and so the responsibility in this relationship is ultimately, when the relationship breaks down, when the system breaks down, it's really the fault of, or more so the fault of, the physician, because their burden is just greater. You might wonder if that's really right, though. I mean, it seems like there are all sorts of ways in which the patient can undermine the process of medical care and medical treatment by not being upfront about their symptoms, or by failing to comply with treatment protocols. So there's a sense in which, when the relationship breaks down, it's as much the patient's fault or responsibility as the physician's. That's just sort of something we can think about. It's not something we have to settle here. Alright, let's move to a more focused consideration of a particular issue in medical ethics that has to do with what the role of a physician properly is, and what the doctor-patient relationship really consists of. This is the issue of truth-telling in medicine. It's well documented that in some instances it's actually better for the patient, medically speaking, if they do not know the truth about their condition. One example from one of the readings that's fairly poignant, that's a non-medical example, but maybe makes the point nicely in a way that's a little less technical. Suppose your patient is on her deathbed, and moments before she takes her last breath, she asks about her son. She says, "How is my son?" And you happen to know that he has just been convicted of multiple homicides and sentenced to life in prison. Is there really any harm in telling her that her son is the truth about her son, or should you just tell her, no, he's doing great, he's doing terrific? I mean, that's a case where it seems like there really is no harm in lying to the patient. But what about, if that's true, that there's not much harm in lying to the patient there, and maybe you're off the boat already, maybe you think that there is harm in that case, what about cases where the physician might think that they should lie to a patient about the prognosis regarding their condition? Because it's well documented that uh, a positive attitude can make a positive difference to treatment success. So if that's true, if believing that you have a good chance of surviving makes it more likely that you actually will survive, why shouldn't physicians maybe not tell sort of their worst off patients how bad things look? Why not do that? What is the harm in that? And so the worry about truth telling really is that we can move somewhat seamlessly from these cases where there seems to be no harm in lying to a patient, for a physician to lie to a patient, to cases where we're not sure, all the way to cases where there really is obvious harm, like a patient or a physician failing to tell a patient about a relevant risk associated with an experimental study or something like that. I mean, that would be a clear case where not telling the patient the truth would be obviously problematic. But there's this sort of moral middle area that's somewhat gray, where this case of wanting the patient to have a positive attitude about their treatment, and we're not really sure maybe what to do about that. Okay, so the problem here is really a conflict, we should note, between autonomy and well-being. We think that sometimes by not respecting patient autonomy, by withholding information or deliberately lying to them, we think that maybe we're making them better off by doing that. We're increasing their chances of survival. We're increasing their chances of recovery. And that seems like a good sort of even trade, or even a net gain in exchange for the slight loss of autonomy, especially if they never know. I mean, what if they never know? Would this really be a problem? Well, there are a couple ways to think about this. Alan Goldman, in the piece that you guys read for this module, argues that this argument that physicians should sometimes withhold the truth from patients assumes that what patients really value ultimately is health and prolonged life. So the problem with this argument, so Goldman is responding to an argument. The argument in favor of what's called medical paternalism is that, look, when a physician lies to a patient for the sake of maintaining a positive attitude so that a positive treatment outcome is more likely, what they're doing is setting back that patient's autonomy for the patient's own good. So for the sake of the patient, they're promoting this value of health and well-being, and that's just more important than the value of autonomy. And Goldman says, well, that's not necessarily true. We don't want to assume that what patients value is health and prolonged life over everything else. We shouldn't assume that the ends and goals of medicine just are the most important thing to patients. So if we drop that assumption, then it's not clear whether physicians should tell the truth or not. And Goldman says, in fact, it's not just an assumption. We actually know that a lot of people don't value health and long life over everything else. People do things like smoke and bungee jump and drive too fast. These are all things and eat terrible food. These are all things that set back people's health and long life, and it's an exchange for some other thing that people value. So we already know that people aren't necessarily willing to sacrifice other goods for the sake of health and longer life. And further, says Goldman, being able to exercise our autonomy is a kind of non-derivative value. It's something that's valuable in its own right. It's not valuable in virtue of what we can sort of get by doing it. It's just a good thing. And so, because of the way in which autonomy is valuable, because it's sort of a good, so the idea here is that even when we make autonomous choices that are really dumb, it's good that we exercised our autonomy, independently of how dumb our choices were. So Goldman suggests that, look, because autonomy is valuable in this way, we can't trade it for other values. We can't sort of exchange it and like lose out on autonomy for the sake of other values. It's a kind of value that cannot be exchanged and traded in this way. Because in some sense, autonomy is actually the basis of value. What Goldman says is a little complicated, but I'll just briefly mention it. He says that things are valuable in virtue of being valued by autonomous agents. So what's valuable is the stuff that we value, the stuff that we care about. And the fact that we care about it is what makes it valuable. Well, if we trade autonomy, which is kind of the source of all other values, for one of those other values, we're undermining the very source of this other value that we're making the exchange for the sake of. I know that's complicated, and I'm not going to ask you about it on any kind of exam or anything like that. But for those of you who are kind of wondering what the discussion at the end of the Goldman was all about, that's kind of what he was suggesting. It's just that autonomy and the fact that we are autonomous agents is kind of a source, it's a basis for other values. So if you were to lose out or exchange autonomy for one of these other values that actually derives its value from the value of autonomy, that's sort of an incoherent or just nonsensical thing to do. All right, let's just take pause here and make sure everyone is clear about the argument here. What Goldman is opposed to is what he calls strong paternalism. This is the overriding of patient choices for the patient's own good. Goldman thinks, look, when we withhold information from patients as physicians, when we lie to patients as physicians, what we're doing is infringing upon their freedom, infringing upon their right to make fully informed choices in light of all the evidence. And we're doing it for the wrong reasons. We're doing it because we think that they care about health and long life more than anything else. And in fact, we know most people don't actually feel that way. So we should go ahead and tell patients the truth, because autonomy is just, we know that autonomy is always more important than other kinds of value, but we don't know that health and long life are always more important. Now, Ackerman takes a slightly different view. He says respect for autonomy, at least in the case of people with serious illnesses, is going to be a lot more complicated than just non-interference with choices. So notice that what we got from Goldman was something like the technician view. It's the idea that the physician's job is not to make judgments about what information to provide and what information to withhold. The physician's job is to just provide information and let the patient choose. So truth-telling is contrary to, or withholding the truth is contrary to that physician as technician conception. And Ackerman says, no. It's much more complicated than this analysis from Goldman suggests. Because in fact, and we saw this when we talked about vulnerable populations, respect for autonomy is significantly compromised by illness. And there are all sorts of ways in which this is the case, and I'm not going to go into because Ackerman does a nice job of laying this out, and it's pretty obvious when you really think about it. There are all sorts of ways in which illness can undermine or impair the patient's ability to make truly autonomous choices. So what the physician has to do is occasionally intervene on the patient's own behalf. So at times when the patient's illness is impairing their ability or affecting their ability to make choices that seem truly autonomous, what physicians should do is intervene. Now, one thing that we can immediately ask ourselves is whether Ackerman and Goldman actually disagree. Because what Goldman is opposed to is strong paternalism in medicine, which is the situations where physicians impose their prerogative over and against what the patient says they want, on the basis of assuming that what the patient ultimately cares about is what medicine thinks they should care about, which is their own health and well-being. And in fact, patients often don't care about those things. So Goldman says, look, we should be opposed to strong paternalism because the assumption that what patients care about is just health and well-being above everything else is not true. And strong paternalism assumes that it is true. And Ackerman says, well, in a lot of cases, patients aren't capable of making autonomous decisions. So what physicians should do is more than just provide information. They should actually try to restore patient autonomy. They should engage with the patient in all sorts of specific ways to try and address the ways in which the patient autonomy has been impaired. You might wonder why we can't do both of these things. Why can't we oppose strong paternalism in medicine and say, look, in the normal standard case, what the physician should do is tell the patient the truth and not assume that what the patient cares about is their own well-being, etc., etc. They should just tell the patient the truth and let the patient make a decision based on all the information and all the data. Couldn't we think that, but also think that the physician should sometimes do more than just provide information? It seems like there's no real disagreement here. So, I mean, that's something that you can think about and that you might disagree with, but it seems to me, at least, that there's really no substantive disagreement between Goldman and Ackerman. They're sort of on the same page, and it seems like we can be opposed to strong paternalism while also thinking that sometimes it's acceptable for patients or for physicians to do more than simply provide information, because illness does, in fact, impair autonomy in all the ways that Ackerman describes. Another thing that you might think about, and we're not going to resolve this here, but it's something you need to consider in light of some of the discussion questions and also the case study for this module, is that if Ackerman is right, what exactly are physicians obligated to do? He focuses on sort of repetition and reframing of information. So we might have to talk to the patient repeatedly about risks associated with a treatment. And we might have to describe things not in terms of likelihood of benefit, but in terms of likelihood of negative side effects or something. We might have to counterbalance the patient's biases and impairments in such a way that we can restore their autonomy. But what exactly does that license the physician to be able to do? I mean, how compulsory, how can the interventions be? What does this open the door to as far as physician interaction with patients? I mean, it's an open question. It's not really clear. It seems like the answer from Ackerman is going to be, well, whatever is necessary to restore the patient to full autonomy. We might worry about what that is going to license, because that might be fairly substantial interferences that we're not terribly comfortable with, regardless of what we think respect for autonomy really requires. Okay, let's conclude by talking just a little bit about two conceptions of the proper role of nurses. The first one comes from Lisa Newton, and this is what she calls the traditional role of the nurse, which is the idea that a nurse should be a kind of subservient caregiver who is subservient primarily to the authority of the physician. And on this conception of the nurse, the nurse actually lacks substantive authority over patient care. The nurse doesn't really have authority to make decisions or changes or adjustments to treatment protocols. Newton thinks that this new conception, this new understanding of the nurse as an autonomous professional is actually somewhat dangerous and somewhat troubling, and she gives 3 lines of argument in favor of that. First, she says, like, the way that hospital bureaucracies are currently arranged, in order for them to function efficiently and effectively, especially in emergency and critical care type situations, we need clearly defined roles and command hierarchies. The last thing we need in the emergency room is another autonomous professional. And that's kind of her second line of argument, is that, look, in really critical medical situations, what we need from nurses is strict adherence to what they're being asked to do, not autonomous decision making, not questioning of whether what's being done is the right thing, not taking a stand against what they take to be sort of an improper treatment protocol or something like that. In times of serious medical crisis, what is needed is a clearly defined command hierarchy. And the place where nurses fit in that hierarchy is in a role of subservience to the authority of the physician. Finally, Newton says that patients have unique emotional needs. They need to be able to vent. They need to be able to express frustration. They need to be able to express concern and fear and be vulnerable. And these needs are such that they can really only be met by a subservient and also non-authoritative caregiver. And the reason in favor of the non-authoritative caregiver is supposed to be that if nurses were endowed with the ability to make changes and adjustments to the patient's treatment, the patient would be less likely to really open up to the nurse about how they're feeling, about what's going on. They'd be less apt to express some of the negative emotions that they might have about the physician or the treatment or the facility. So because the nurse has really no power to change any of this stuff, it's not threatening, it's not dangerous or risky to tell the nurse exactly where the patient stands. And Newton says, look, this is a very important need that patients have. In fact, this is the attentiveness to these kinds of needs are really the only thing keeping medicine as a kind of caring profession. It's really the only thing keeping it from becoming what Newton refers to as a moral monster. And so in that sense, the role of nurses is incredibly significant. But in order for the nurse to meet the emotional needs of the patient, they ought to adopt this role of a subservient caregiver who lacks authority over patient care. And Newton takes pains to note that, for example, just occupying a role of subservience in your professional life does not amount to a full loss of your autonomy. You may have freely and autonomously opted into a profession like this, and within your own life, you might still operate very much like an autonomous agent. There's a significant difference between someone who's forced into a position of subservience and one who autonomously chooses to take on an occupation of that type. So this does not amount to, there's some sort of feminist concerns here. And Newton takes some pains to try to press against that. And she also, the other sort of feminist concern that comes up is that this is somewhat a caricature, whereby it seems as though nursing is just sort of a proper job for women. And Newton points, because the way that the role is described, it embodies the qualities that are sort of stereotypically ascribed to females. And Newton notes that, in fact, assuming that that's true is itself the very type of sexism that feminism is supposed to be opposed to. So she thinks that at least those two lines of argument and response can be effectively responded to. Helga Kuess gives the alternative view. She says, actually, this subservient, non-autonomous nurse is likely to do more harm than good. So we should be very wary of this conception of the nurse, and actually the nurse as autonomous professional is really much preferred. Kuess's argument is a little bit more nuanced than Newton's. She starts by talking about the essence and then the function of nurses and doctors, and she says, number one, we should think of professions as constantly evolving and changing. We shouldn't think of them as having sort of an essential or fundamental nature. They're going to change and evolve as social needs and social mores change and develop. And in terms of the function or sort of purpose of nursing and medicine, it's not abundantly clear that there's a sharp distinction between the two. Similarly with philosophical commitment, she defines these in terms of a commitment to care versus a commitment to cure, and she says, in fact, this is highly problematic for a couple of reasons. For one thing, a nurse that was more cure motivated than care motivated would then technically count as a doctor in virtue of this philosophical commitment, and that's just clearly ridiculous. And really all Kuess is doing in this section is challenging the notion that we can talk about sort of a fundamental or essential conception of a particular role. She's really placing a high emphasis on the fact that these these roles are socially prescribed and they can develop and change as the social environment changes. Then she engages specifically in a couple of the arguments from Newton. One is this argument that within the hierarchy of hospitals, because of the nature of especially sort of high stress and dangerous trauma type treatment, what's really needed is a very rigorous command structure. And in virtue of the special and unique expertise level of physicians, they belong at the top of that structure. And Hughes points out in a number of different ways that even if physicians do have this unique level of expertise, it just doesn't follow that nurses should always be subservient to physicians. For one thing, there are plenty of scenarios that arise, even in sort of emergency situations, where nurses have the appropriate level of expertise, where their nurses are much more highly trained and skilled these days than they have been in the past. And so there really isn't this huge knowledge gap and this capability gap that there once was. Further, even if it's true that in these sort of circumstances like emergency rooms and surgery, operating rooms and things like that, even if in those circumstances this hierarchy is necessary, it doesn't follow that all nurses everywhere should always just be subservient to physicians. And in general, what Cuse is really worried about is defining the nurse's role in such a way that the obligation of subservience and non-autonomy is absolute in the sense described by Newton. Cuse thinks that there's something to be said for having other people involved in the medical hierarchy who do have some authority, who do have some capacity to speak on behalf of the patient when they feel that a decision is improper, inappropriate, or not in the best interest of the patient. So by endowing nurses with the ability to speak and sort of resist and exercise their own autonomy in a certain way, we're not necessarily undermining the authority of the physician. What we're doing is actually creating a kind of check and balance system in order that patient needs and interests can be better met and protected. And finally, with regard to this argument that the emotional needs of the patient can really only uniquely met by a non-autonomous subservient nurse, Cuse thinks that actually the opposite is true. Number one, many patients just don't have these emotional needs that Newton discusses, and so there's no need for sort of all nurses to occupy this subservient, non-autonomous role. But in addition, there's a worry that this emotional need that many patients do have would actually not be met by a non-autonomous nurse, because the patient might feel like their concerns are not being adequately addressed or adequately attended to, because the nurse has no authority to make any adjustments or changes. So there's a concern that although the emotional need in the form of kind of a venting or expressive component can be satisfied, the emotional need to have one's concerns genuinely listened to and responded to, that is not being met by the non-autonomous nurse, because she doesn't have the power to bring any of those concerns to fruition, to change the scope of the treatment, for example, in order to meet these needs. So there's a worry that actually the patient's emotional needs are less likely to be met if the nurse lacks autonomy. Now, it's a discussion question for you guys, so I'm not going to say much about which of these conceptions seems correct to me, because I think there's some merits to both, and that's really what I think in formulating a discussion board answer, that's what you really may want to start by focusing on, is what are sort of the positive features of these different conceptions of the nurse. We get this sort of extreme with Newton of the subservient non-autonomous nurse, and she's responding to this idea of a nurse as a kind of autonomous professional, a sort of less trained doctor within the medical environment. And it's not clear whether Cuse is advocating this sort of extreme autonomy view or a more nuanced and kind of balanced moderate position. So that's something that you should kind of consider as you're thinking about the proper role of nurses. All right, what's the bottom line? I think there are at least 3 points that we can take away from this module on this discussion. First, it's that the doctor-patient role is almost certainly more nuanced than either the technician or the omnipotent conceptions suggest. Again, the technician position seems to really emphasize patient autonomy without taking seriously the extent to which autonomy is compromised in medical situations, and the omnipotent conception has the problem of just really not taking patient autonomy seriously at all and failing to account for the extent to which medical expertise is really limited to the broader, with regard to answering the broader question of what's really good for the patient, because that's a question that includes but is not limited to medical and health considerations. Second takeaway point is that it seems, at least to me, although we can disagree about this, that physicians can avoid the strong paternalism of simply overriding patient choices for their own good without occupying the technician role. It doesn't seem that the concerns that Goldman raises about failure, sort of assumptions about patient value hierarchies, assumptions about what patients really care about. It seems like we can avoid making those kinds of assumptions while still attending to the very real considerations that Ackerman raises, the extent to which being a patient limits and impairs one's autonomy. So it's not clear that Ackerman and Goldman, although they're sort of juxtaposed as one opposed to paternalism and one advocating for intervention, it's not clear that they're actually opponents. It seems like there is a way in which they are advocating the same kind of thing, the same kind of role for the physician. And finally, I think we can conclude that it continues to be an open question whether the traditional role of the nurse as a subservient caregiver is desirable. The move at present is towards this conception of the nurse as the autonomous professional, but in light of some of the considerations raised by Newton, which Cuse sort of takes with a grain of salt but does agree with to a certain extent, we should at least keep in mind the positive features of that role before we simply redefine what the role of a nurse properly is. We should maybe try to find a way to retain the autonomous professional, the positive components of the autonomous professional, but also incorporate these more traditional roles of the nurse that did serve a purpose and function related to meeting patient needs.